Hello, everyone. My name is Chiranjeev Dash, and I am really grateful and I thank the organizers of AllyCon and the Colorectal Cancer Alliance for allowing me to speak about some of the work we do and some of the work we are really interested in around colorectal cancer disparities. I'll be speaking with Dr. Jackson about equity in cancer care and the importance of self-advocacy in improving equity and reducing health disparities. I'll primarily talk about disparities in risk factors and screening. And the reason I would do that is I'm a cancer epidemiologist working in colorectal cancer and breast cancer prevention and control. And most of my work is in underserved populations and working in minority health and health disparities. I'm the Assistant Director of Health Disparities Research here at Georgetown Lombardi Comprehensive Cancer Center. And with my colleague and mentor, Dr. Lucille Adams Campbell, I also coordinate outreach and engagement activities for the Cancer Center, which is why I work really closely with advocates, community-based organizations, and a really wonderful advisory council that tells us how and directs us how we can do more research and activities to reduce disparities in the Washington, D.C. metropolitan area. I do not have any conflicts of interest to disclose. So let me start by laying out a background of where we are going as a nation. Every 10 years or so, we come together as a nation, and we set these data-driven national objectives to improve health and well-being over the next decade. The new plan, which you can find at health.gov, has been laid out, and the vision is a society in which all people can achieve their full potential for health and well-being across the lifespan. The Healthy People 2030 lays down certain foundational principles, and I'm going to highlight a couple of those foundational principles. The first one is that the health and well-being of all people and communities is essential to us achieving our goals. And second, it lays out the primacy of eliminating health disparities and achieving health equity to be able to achieve our goals through Healthy People 2030. So where does colorectal cancer figure in our plan for the next decade? One of the major cancer control and prevention plans in Healthy People 2030 is to increase the proportion of adults who get screened for colon cancer. Right now, based on our most recent data, that number nationally is 65%. So 65% of the adults in the United States, are screened for colorectal cancer in a Guideline Concordant way, and we want that number to go up to about 75%. So there's a little bit of work to be done in that area. And the second thing that shows up in Healthy People 2030 is related to improving treatment and access to treatment. So reducing the colorectal cancer death rate, which currently is around 13.2 per 100,000 population, to less than 9 per 100,000 population. Again, we want to get there within the next 10 years, and we would have to work together to get there. I really like this new vision for Healthy People 2030 because it makes it clear that we have to work together, not just policymakers and those in academia and researchers, but every one of us. That includes us as individuals, organizations, and advocates. And it lays out a blueprint for how we can help get to these goals. So no matter who you are as an individual or organizations, or as a researcher such as myself, what the Healthy People 2030 lays out is to identify needs and priority populations. So if I'm talking about colorectal cancer research, I would like to find out what are the needs, what are the underserved populations or health disparity populations, and what is the status of the data in those populations. Then we set our own targets, or we use targets and benchmarks in Healthy People to get there. We find inspiration and practical tools from all the materials that we can find on Healthy People 2030, and then we use national and local data to benchmark our activities as organizations, how far we are from our goals. So you have heard about colorectal cancer disparities earlier in the conference. I am going to focus a little bit more on some select social determinants of health and their impact on colorectal cancer disparities. Most of the data you have seen or heard is around race, ethnicity, and access to treatment. However, there are multiple social determinants of health, and I've pointed out some of it here on this slide where disparities exist in colorectal cancer. We know about race, ethnicity, but those who do not have proficiency in speaking English language, also have disparities in colorectal cancer. They have higher mortality rates and incidence rates. Immigrant status, low educational level, lower income levels, lower socioeconomic status, age, gender and sex minorities, and geographical disparities, rural populations living in areas with high poverty. And finally, I'll also talk a little bit about how the risk factors for colorectal cancer and differences in the distribution of those risk factors can lead to colorectal cancer incidence and mortality disparities. By the way, when I talk about incidence, I'm talking about the diagnosis of new cases of colorectal cancer every year. So the American Association of Cancer Research points out that these are the groups who face cancer-related health disparities. And we have talked about it a little bit. Individuals with low socioeconomic status, people with disabilities, immigrants, the elderly, and individuals who lack or have limited health insurance coverage. So let's look at a little bit more at what some of these disparities might be. Do we have disparities in incidence and mortality of colorectal cancer? So what I'm showing you now are trends of colorectal cancer new diagnosis, which are the top two of these curves, and deaths from colon cancer in men and women across a broad time period coming from the 1930s to our current time. What you see on the y-axis over here is the rate of either the new cases being diagnosed or death rates. And what you will see is that over time, since the mid-80s, we have been doing well as a nation. Our war on cancer and the research and treatment advances that we have seen are showing effect that colon cancer incidence, new cases of colon cancer, are coming down in both men and women. And since the mid-80s, we have also seen a decrease in colon cancer death rates due to increasing treatment and survivorship advances. However, these advances and these benefits are not equally distributed across all race ethnicities. What I'm showing here again is the similar graph, but now instead of looking at it by gender and sex, we're looking at it by race ethnicity. In the top panel here, we're looking at trends of new cases of colon cancer over time. And as you can see, the rate of decrease in colon cancer has been much more rapid in whites and started earlier in whites as opposed to African Americans or blacks and in Hispanic populations. What you're also seeing here is a concerning plateauing and a slight increase in new cases of colon cancer, especially among African Americans. We see a similar situation in mortality. Mortality reduction among whites started much earlier than among blacks and among Hispanics. And there is still a difference in colorectal cancer deaths between African Americans, whites, and Hispanics. With Hispanics, because of their lower incidence, They also have a much lower mortality rate than both blacks and whites. However, the reductions in mortalities that we have seen across both blacks and whites, we are not seeing in Hispanics. We can also look at disparities in colorectal cancer new diagnosis and death rates by age. And this is something you must have seen in the news and heard from experts recently. In the 65 plus population, since the mid 90s and later on, we have seen a reduction in both male and female new diagnosis of colon cancer, presumably as a result of colonoscopies, which remove adenomas that might go on to form cancer, thereby preventing colorectal cancer, and perhaps by better attention paid to some risk factors for colon cancer. However, we do not see the same pattern in the 50 to 64-year age group and the below 50-year age group. In fact, if we look at the age group below 50, we're seeing a concerning rise in cases of colorectal cancer. What about death rates? If you look at death rates, we see a similar pattern. Death rates in the 65 plus age groups are going down, perhaps as a result of finding cancer early and treatable cancers and by better treatment of such cancers. However, in the 50 to 64-year age group, we're starting to see a plateauing of decreasing death rates. And even more concerning, in the below 50-year age group, we're starting to see an increase in death rates from colon cancer. So what we have seen so far is that the disparities that we see are not just race, ethnic, or income and insurance disparities. They're across genders, they're across age groups, and they're across race, ethnicity. Another way to look at these disparities is to look at geography. Does the entire United States have the same impact from colon cancer, new diagnosis, and mortality? The answer is no. As you can see, there's this area in the Midwest and the Southeastern United States which carries a higher burden of colon cancer new diagnosis and death rates. Is there something specific about living here? What is it about these geographies? Is it about rural areas and urban areas? Is it about more people in those areas belonging to minority populations? We don't know. We don't have all the answers, but the probable answer is probably it's a mix of all of those together. And if we add on to geography and look at income status and socioeconomic status, what we find is that men living in poorest counties in the United States have a colon cancer death rate that is 35% higher than men living in the most affluent counties. So this is the complicated data. The nature of disparities is complicated. It goes across different social determinants of health, including income, access, age, geography, race, gender. And we will have to come together and think of creative solutions that take all of these into account if we are to reach our 2030 healthy people goals. So why do we see these disparities in incidence and mortality? Let's look at some of the common risk factors for colon cancer. The American Institute of Cancer Research and the World Cancer Research Fund regularly publish reports on the state of scientific evidence on risk factors for common cancers. And what I'm showing you is our state-of-the-art evidence for colon cancer. We have convincing evidence across multiple studies in multiple countries that states that physical activity strongly decreases risk of colon cancer. On the other side, having excess body weight, drinking alcoholic drinks, and eating processed meat increases the risk of colon cancer. Can the different distribution of these risk factors And let's for today focus on body fatness, what we would call overweight, obesity, and physical activity. Do the differences in colon cancer incidence and mortality do we see, might they be explained by some of the differences in physical activity and body fatness and disparities in them? Let's look at what the data says. But before we do that, the American Association for Cancer Research in a recent report asks about what are the risk factors that cause disparities. And you'll see here some environmental risk factors, behavioral risk factors, some of which we just talked about: diet, physical activity, overweight, obesity, social factors, clinical factors, and other cultural factors. If you look at risk factors that are associated with increasing cancer risk and cancer disparities, excess body weight and physical inactivity, in addition to diet and alcohol, all of which are related to colorectal cancer, figure high on this list, which suggests that if we could reduce disparities in these risk factors, we might reduce disparities in colon cancer incidence and mortality. And here is the state of concerning data about obesity. What you're seeing here is obesity disparities, not just by geography, but by geography and race ethnicity. This first map over here in the top left corner is non-Hispanic white adult obesity distribution across the United States. And what you'll notice is that this Midwest and Southeastern area and the states that I showed you are high in colon cancer incidence and mortality are also highest for obesity among white adults. It's the same area, much higher obesity rates among Black adults, and among similar areas, even among Hispanics. What about physical activity? We see a similar pattern. What this map is showing you are proportion or prevalence of adults meeting weekly physical activity guidelines. More blue, the darker the blue, more the proportion of population meeting physical activity guidelines. For example, if you look at the Northwestern United States, about 55 to 60% of people, adults living in those states, are meeting physical activity guidelines. Whereas if you look at some of these states, the Southwestern and some of the Midwestern states, that number is pretty low, close to about 35-40%. Given that physical activity is a strong risk factor for colon cancer, might these geographic disparities explain some of the geographic disparities that we see in colon cancer risk? The other preventive risk factor I'll talk about is colon cancer screening. Here are the most recent colorectal cancer screening guidelines from the American Cancer Society. Colon cancer is one of those cancers for which not only do we have evidence-based guidelines and screening tests that have been shown to reduce deaths from colon cancer, we have multiple tests. We have stool-based tests like the fecal immunochemical test, and we have colonoscopies which can not just diagnose cancer early, but by removing adenomas can prevent future cancer risk. Cancer screening guidelines suggest that people start at age 45 and continue with a testing option that they like based on their discussions with their physicians. However, there is a strong geographic disparity in how many people or what proportion of a population in some of our states get these colonoscopy screening. You see up here, Massachusetts sits somewhere at 75%, which is very close to where we want to be for our 2030 Healthy People guidelines. But down here, Oklahoma, New Mexico, Alaska, Texas, Nevada, Wyoming, the rates are less than 65% and close to 60%. So there is a large geographic disparity in what proportion or who gets screening for colorectal cancer. We see that disparity in age groups too. People 65 and above, 66% of them are current on their colonoscopy guidelines compared to only 42% of those between the ages of 50 and 54. Compared to whites and blacks, which are closer to 60% on colonoscopy guidelines, Hispanic, American Indian, Alaskan Native, and Asian populations are much, much lower. Those belonging to gender sexual minorities also have disparities in accessing colonoscopy screening. We can continue seeing here. We see that those with fewer years of education, those who were not born in the United States and are immigrants, those with income levels below the federal poverty level, and those who are uninsured or insured with Medicaid all have disparities in colorectal cancer screening. So how do we address these disparities? I really like this graphic put together by the American Association for Cancer Research. It makes it clear that people and different groups have to come together if we are to achieve health equity, and address health disparities. It has to be patients and survivors and their families. It has to be health care providers. It has to be the researchers, the pharmaceutical companies, individual citizens, policymakers, regulators. And that is the power of organizations such as the Colorectal Cancer Alliance that bring all these groups together to come up with solutions. Sometimes when I teach students about health disparities, it seems like the picture we paint for them is that it's a really huge problem and it'll take years and years and years to fix this problem. However, I also like to point out to them that that might not necessarily be true if we can all come together. Let me give you an example. This was a publication a few years ago talking about eliminating racial disparities in colorectal cancer. This was kind of a cancer control effort in the state of Delaware. And I really like, what I really want you to focus on is even the investigators or the researchers realized that it took a village. It took a village to get there. What did they do? They didn't do anything that you wouldn't logically expect or we have heard about. They decided to come up with a colorectal cancer control program that included giving access to colorectal cancer screening irrespective of income or insurance access, cancer treatment program for the uninsured, and emphasis on disparity reduction in African Americans. So what did they find? If you look at the table, their baseline, or when they started, was at 2001, where there were big disparities between blacks and whites. Fewer blacks had colonoscopy. More of them were getting diagnosed with colorectal cancer, and the mortality in African Americans was 30% or more than 30% compared to less than 20% among the whites. This program that started in 2002, 2003 and went on for 6 years, within about 7 to 8 years, you see the impact. The screening rates rose both in blacks and whites, but there was no disparity between both groups. Incidence in blacks came down. The mortality rate, look at the dramatic difference in mortality rate that came down from 31% in 2001 to 18% in 2009. It took the legislature, nurse navigators, healthcare providers, community-based organizations that talked about this program, and community health workers all coming together to achieve this. So this is real-world example that we can all do, and we have real-world examples of achieving equity, health equity in colorectal cancer disparities. At Georgetown, we are working with different organizations and different healthcare providers to try to increase colonoscopy screening, fecal immunochemical testing, and providing access to treatment for those who are diagnosed through these screening programs. We're hoping we can come together with you as individuals and organizations to continue our good work. Thank you for allowing me to speak on this issue that we are all passionate about. And you can find more information about our office at minorityhealthdisparities.georgetown.edu. Thank you.
Good afternoon, and thank you for the invitation to present today. I am Dr. Patrick Jackson. I am the Chief of General Surgery here at MedStar Georgetown University Hospital. I've been asked to talk about health disparities and an opportunity for advocacy. This talk is one in which we will remark on various differences in care that we have noted, and unfortunately, as we talk about health disparities, we'll have to confront issues that I think aren't limited to colon cancer, but affect subgroups of our population, of the American health landscape, and some of it we can explain, and some of it we can't. And you may be left with more questions than answers at the end, but I hope it opens up a dialogue that I think is useful. So as we talk about things, I will talk about disparities that we've seen in both in screening and in treatment, in outcomes and in survivorship, and then look at opportunities for where we can improve those things. These are just some examples of differences in screening. There's generally, unfortunately, a very low awareness across the board, regardless of your background, of the various screening tests that are available for colorectal cancer. That low awareness of screening leads to an increased likelihood of symptoms being the reason why people get a screening test, in that they're not aware of those screening tests ahead of time. As there is a disparity among groups, a racial disparity in the recognition of those screening tests and the need for screening, it tends to be that African Americans and those of Hispanic origin tend to present later in disease process because of the recognition of need for screening, and therefore presenting with symptoms rather than presenting just for screening, in which case it was found prior to the onset of symptoms. There are also, interestingly enough, differences in the tumor profile. There's differences in the tumor microenvironment between different racial groups. Let me paint the larger picture, that cancer is unfortunately your own body, and your immune system's major job is to find and identify what's you, and then identify what's not you, and then try to attack what's not you. And that's it does, and that's how bacteria are identified, or viruses, or any foreign object. Your immune system identifies things as not you and tries to attack it. Cancer is unfortunately you, and therefore it's you, but a little bit wrong. And the more robust you have of an immune system response to the tumor, the more your immune system is identifying that tumor as not quite you and trying to attack it, and therefore the immunogenicity, or the immune cell infiltration, has a protective effect. In the rest of my slides, as you see, I'll use various terms interchangeably. Non-Hispanic Black is NAHB, or African American. Non-Hispanic White, NHW, or Caucasian. So immune cells are protective, and non-Hispanic Black patients have lower rates of immune infiltration. Therefore, their immunogenicity of their tumor doesn't highlight as much, and therefore their body isn't working as effectively to try to attack that tumor. There are also different expressions of genes that some tumor suppressors are more common in the white population than the African American population. And then obviously there are racial disparities in overall health status. Those disparities can be secondary to socioeconomic factors, but they can also be secondary to epigenetic phenomena or other impacts of our long-standing differences in health that tend to affect different populations. There's also disparities in treatment. This is one example that I pulled from an article that looked at the National Cancer Database. That's a database that's organized by the National Cancer Institute, and looked at 10 years of data and found that African American patients were less likely to get an operation and less likely to receive chemotherapy over that decade. There was an improved survival at some academic medical centers for all races, but even at academic medical centers, racial disparities still exist. There are other studies, a number of studies, that show a link between the presence of insurance, none versus Medicaid versus private insurance, and the receipt of chemotherapy. That gets us to a discussion of what I will call guideline concordant care. What that means is there are guidelines for every stage of cancer care, regardless of the type of cancer. For colorectal cancer, stage 1, for example, means you should get an operation first. You're not eligible for chemotherapy in the current guidelines of care. Stage 2, stage 3, stage 4, each of them have subdivisions, and within each stage, and with each substage, there is a guideline for what care should be delivered to that patient. And so when we look at data, we should look at whether or not the patients within that stage received guideline concordant care, because if they didn't, well, then maybe that explains the difference. It turns out that in a study from the Journal of the National Cancer Institute, non-Hispanic Blacks were more likely to receive guideline concordant care, meaning they were more likely to receive the care that was recommended for their stage. But being African American was independently associated with a higher recurrence and higher mortality, even though they were more likely to receive guideline concordant care. It's a little counterintuitive. Even when you looked at just the patients who received guideline and concordant care among African Americans and white patients, you looked at only guideline concordant care patients, African Americans had a higher recurrence and a higher mortality. There's also differences in survivorship. When you match everything for demographics, socioeconomic status, presence of insurance, what are their other health characteristics, African Americans have a lower survival when matched for all those demographics. Their insurance status does have an impact on survival. Tumor characteristics also have an impact on survival. But even when you isolate for these two, those two do not explain all the differences in survival, in the survival differences seen by African Americans when compared to Caucasians. There's a number of barriers that race or socioeconomic status can play, can create to cancer care. Lack of insurance, poor patient communication, the cost, a differential perception of risk, and a lack of trust. Interestingly, let's talk a little bit about community. What are the advocacy? What can we do rather than just seeing all this data and realizing that there is this difference that is tragic and has impact on our different patient populations differently, and that alone is hard to sort of wrap your mind around and say that's wrong. But what do we do about it? Well, let's talk a little bit about community advocacy. Back in 1971, President Nixon declared a war on cancer. And what did that mean? It means that we were going to try to marshal all resources to try to address this public health issue. And since that time, there have been significant improvements in survival. As our aging population, as our population ages, and that those improvements in survival from an original malignancy, we also have to then consider what are the long-term effects on the treatments that we give that have improved our survival, but may then lead to other risks, whether it's what we call mantle radiation, like radiation to the chest for somebody who has lymphoma, that then goes on to increase their risk of other diseases such as thyroid cancer, or the impacts of the chemotherapeutic regimens that they have received to increase their survival, and then secondary effects on either their bone marrow and their immune system or other systems in their body, increasing risks of other diseases, everything from problems with how their heart functions to how their lungs function, secondary to chemotherapeutic effects, and the long-standing issues of radiation on your intestines, for example. I think it is really important, therefore, and when we think about community advocacy, is to think about both quality of life and quantity of life. Like, are we just helping people live longer, but are we also, in helping them live longer, helping them actually live better? And are we improving their quality of life? Can we address issues of not just how long they live, but how well they live? Both of them are adequate goals of care. As we think about community advocacy, I'm going to mention also screening. Many of you may know that some institutions throughout the country are known as comprehensive cancer centers. That is a designation created by the National Cancer Institute that evaluates whether or not the institution has all of the aspects needed to manage all different types of malignancy, not just the most common ones, but all the different aspects of addressing malignancy, like survivorship and allyship, and how do we follow patients after they've been long-term survivors of their colon cancer or breast cancer, and how do we then look at the genetics such that they have family members who also may have a risk of developing malignancy. So you may not know this, that all comprehensive cancer centers in in their charter of being a comprehensive cancer center, have an annual requirement to identify gaps in cancer management. That is a huge opening for increasing screening among comprehensive cancer centers, creating a multi-pronged strategy. I think that multi-pronged strategy for every cancer center, and certainly for those that are required to do it annually, should involve some amount of patient navigation and population-based outreach, as well as advocacy organizations like Colon Cancer Alliance. That's where the community advocacy can be so robust to make a real difference, because you're looking at populations of people, like large groups of people, not just the individual person that any one physician will see, because the individual physician treats the individual patient, but a comprehensive cancer center, or certainly an advocacy organization that can have outreach far beyond the role of the comprehensive cancer center, can just have an impact that is much greater than the one individual. Now, I derive a huge amount of personal and professional satisfaction by helping the one patient, but advocacy organizations can have impact on a national or even larger level. Let's talk about treatment and community advocacy for treatment. The Affordable Care Act has an associated Medicaid expansion. Before the Affordable Care Act, African American patients were less likely to receive timely systemic therapy. We talked about that previously, in differences among patient populations in receiving systemic therapy. With ACA Medicaid expansion, the disparity in the delivery of systemic therapy was eliminated. That alone was a great effect of the Affordable Care Act, and understanding that the Affordable Care Act has led to opening up of access to care for a population that was previously excluded from it because of lack of insurance through no fault of their own. Then having this Medicaid expansion, which thankfully most states did take advantage of, some didn't, but most states did take advantage of. And this Medicaid expansion actually really had an impact. It's a fascinating study that was really showed the impact that this can have on a statewide level. Let's talk about outcomes. Community advocacy. Even though African American patients were more likely to receive goals concordant care, their outcomes are worse. And although some subtle differences can be found, like where they had slight tumor differences or social determinant, tumor differences and immunogenicity may explain some of it. Social determinants of health may explain some of the rest of the outcome, and therefore community advocacy to try to improve overall social determinants of health can have an impact in outcome. But I think the other thing that we have to talk about is self-advocacy. So go from the community down to the individual. And so how do we advocate individually? What is self-advocacy in this setting? I often talk to patients, whether or not they are mine or just family members or friends, about how to prepare for your treatment. And there's always people sort of think about, how am I going to guard up for battle to fight this tumor? And I think there are things that you can do that will improve your ownership of your of the work that your family, that your allies, that everybody does to help fight this disease. I think you really do have to prepare. You have to organize your information. You are the number one recipient of your information. physicians, individual physicians may see you and give you information, give you their impression. They're an individual. They will give you what they think that you should do, and what they think they should do with you to help treat your tumor. But get a notebook and own that information. Keep copies of all of your visits, your pathology reports, every biopsy you've had done, any op notes you've had, any x-ray reports you've had. Start owning your own information. Keep that with you. It is useful for you to type up your medical history and medications and allergies, because every time you go to any physician's office, this is likely what you will be asked. I would strongly recommend that, to the extent possible, that you bring a family member or a friend to basically every visit, because there's good data that says that patients remember about a third to half of what I tell them. And so if you bring somebody else, at least that will be more. It may not be 100% of what I tell them, but getting more data when you walk out. Take notes, write stuff down. You should get a second opinion. You should get a third opinion. Often, patients and we as a society, we are taught to trust doctors. That leads to the idea of the first doctor who tells me something, I'm just going to trust that as the truth, rather than that individual doctor's opinion. Now, my care, the care that I provide a patient, is not about me. And so what I tell every patient is that I really welcome second opinions, because while I think I'm right, some other person may see some other information in your story or history or physical exam or x-rays or biopsy that they think should be managed a slightly different way. And you should see as many people as possible as it takes for you to say, okay, I am comfortable with this treatment strategy. And as I tell people, if I'm going to go to 3 different car dealerships before I buy a car, I'm certainly going to go to 3 different doctors before I buy into what's going to be a strategy for the management of a cancer that I have. When you go to a physician's office and you're talking about a cancer, you're going to need to ask at least these questions. You're going to ask as many questions as you can, but you're going to want to know your stage. You're going to know what are the treatment options for that stage. You're going to need to ask, what is the standard of care for this stage? That is an important phrase to use, because it means that you're saying, I understand that you may be telling me one thing, but if without me personally here, what are the guidelines of care? What is the standard of care? What are the current guidelines for my stage? And then make it unique to you. What are the unique aspects of my case that would make you consider other options, or has made you conclude that this option, which may not be the standard of care, but we're choosing to go outside the standard of care because there's something unique about my case? Those are legitimate questions. There are other questions, but you can't ask too many questions in that setting. Getting as much information will empower you to make the right decisions about your care. That's the best way to start self-advocacy. I thank you for the opportunity to present this information and for the privilege of the podium.
Good afternoon, everyone, again, and thank you for joining us for this session. It was a privilege to talk about equity in colorectal cancer care, and I'm really, really happy to be joined by Dr. Patrick Jackson. So, Dr. Jackson, I'm going to go through some of the questions that we have gotten, and then maybe we can have a discussion around it. One of the most interesting ones, and there were multiple questions around it, is the young onset colorectal cancer. Most of our research is around adult, colorectal cancer in 50 and above, 60, 65 and above. And it seems like a lot of the risk factors, and someone pointed out on the chat, is that some of these young people with CRC are very active, they exercise, they are hockey players, and they still end up with colorectal cancer. So from an epidemiologist point of view, I'll be humble and say, we really don't know. But for a lot of the risk factors for young onset colorectal cancer, there are a lot of research studies going on. What we do know is that about more than 90% of them are still what we would consider sporadic, which means there is no single gene mutation that is causing these colon cancers. Dr. Jackson, any insight into that?
Thank you. And also, as I said, thank you for the privilege of what we call the podium, being able to speak in this setting. The other thing I would say is, while there are some risk factors that are malleable, ones that you can change, sometimes people focus on those and then feel like that they were responsible for their own tumor, which could not be farther from the truth. There is nobody who deserves to get cancer. Let's just start there, right? And so if you or a family member or anybody you know happen to get a malignancy, even if there are risk factors in your life that are changeable by you or not changeable by you, it is not your fault. You did not cause it. It is not something that you like made happen. We all try to stay healthy. And so, you know, I try to exercise. I don't do as much as I should, but I try. And so should I get heart disease? I would say that that's unfortunate, but it is not my fault. I think there are different aspects of things that we can try to do, but to my knowledge, there is nothing that is causative, that is like, okay, this is the one thing you did that caused it. And there's been a pattern of younger onset and more what we call right-sided lesions. For those who haven't thought about this or not studied the anatomy of the colon starts on the right side in the right lower abdomen and then goes up and then over and then down and then around and then out. And so there's the right colon, the transverse colon, the left colon, the sigmoid colon, the rectum, and then the anus. And so there's a general trend towards younger onset and more right-sided lesions. And unfortunately, right-sided lesions are also more likely to be flat and therefore harder to have picked up and more likely to be metastatic. And so this is a pattern that we are seeing, but not from the cause of anybody. It's just a factor that happens. I am glad that all of the recommendations have moved towards more younger screening, because that means we're more likely to find them sooner, although not perfect. You know, I'm glad that most of the task forces and most of the guidelines have now moved towards the 45 just as a screening tool.
Yeah, and that's one of the questions. Why don't we go below 45? As someone who has been involved in the colorectal cancer screening guidelines process, it's an evidence-based decision. We don't have enough evidence to say all adults below the age of, say, 49 or 45 should get routine screening irrespective of symptoms. Because even now, for the 2020, for example, of all the colon cancers diagnosed, only 7% were in ages below 50. So it's rising, but the majority of cancers still detected and treated are in the older age group. So the other thing to remember is that all screening tests, including colonoscopies, come with their own set of side effects. There could be complications. So unless we have good evidence suggesting that we can actually find and treat these cancers, we're just not at that level yet to recommend going below 45. Having said that, they do say that you talk to your physician, and your physician, depending on your family history or depending on your some of the known genetic factors, might, or if you have inflammatory bowel disease, might decide that you qualify for screening tests below the age of 45. And that's, Dr. Jackson, correct me if I'm wrong, that's what we see for most inflammatory bowel disease.
That's correct.
So, and yes, screening is covered by insurance since the Affordable Care Act, what's considered a screening colonoscopy, you don't even have to pay copays. It's obviously slightly different across Medicaid, but most private insurance and for Medicare, you do not have to pay copays for or deductibles for what is considered screening colonoscopy. And then there are some questions about diet. What food should be avoided as a colorectal cancer patient? Have we considered cultural differences in diets in thinking about response to treatment, so on and so forth? So, Dr. Jackson, for colorectal cancer patients undergoing surgery?
Well, undergoing surgery has its own specific group. Most patients who undergo an elective operation have gotten a bowel prep. And so there's usually a diet change right around the time of an operation. Let me make sure that people understand the definition of elective surgery means you get to choose the date. It didn't happen as an emergency. Colon cancer is in general, most colon cancer, somewhere between 70 and 85% of patients who present with colon cancer get to choose their date. You know, I want Thursday versus Wednesday. Okay. They will have a specific diet around the actual operation, but the question more is overall, like what diets will help with my cancer management as a long-term strategy, other than high fiber, which is and low fat, would both of them generally better for your health. I don't personally know of any specific changes to diet. I know a lot of people who try to reduce processed foods and reduce processed sugar out of their diet as a general way to become healthier, but I don't know if that's been studied specifically for colon cancer and if it has any specific difference in outcome from the cancer itself, other than just improvements in health.
And for some of the survivorship research that we do, what we have seen is that the general recommendations for diet, not a specific dietary item, but moving towards a healthier diet, more fruits and vegetables, as Dr. Jackson mentioned, less processed foods, more water instead of juice or other, sugary beverages. It seems like that has been the recommendations, and going forward, those would be the general recommendations, not just for preventing cancer, but also having a healthy lifestyle after cancer. And what you would read in the news that there are lots of dietary recommendations, like the DASH diet, which is the dietary approaches to stop hypertension, the Mediterranean diet. Those are all just guidelines and recommendations, and all of them have the same, the constituents: more fruits and vegetables, more complex carbohydrates, more fiber-rich foods, and then less sugar and less processed meats. So, but there are no specific food items to either eat or avoid. Let's see some. Oh, this is a good one. What can we do to increase diversity in clinical trials when clinical trials are so demanding on patients, and the cost of participation is also a major limiting factor? So
it's a brilliant question. That is a challenge for the entire medical community, and that's true not just for cancer, certainly for colorectal cancer. It is true for all diseases. Like increasing the diversity of our research to make sure that when we are addressing a health condition, the things that we are addressing applies to the entire population is an excellent point and a huge challenge for the medical establishment. That's a very insightful question that if I could solve it, it would be phenomenal.
And just to let people know, cancer centers, comprehensive cancer centers around the country, including our Georgetown University Lombardi Cancer Center, we are one of the National Cancer Institute grantees for the National Community Oncology Research Program. So the NCI gives us this grant, and the only purpose of this grant is to increase minority participation in clinical trials. So there is work going around. Obviously, we need a lot of improvement, but there are policies in place and more work put into how to not just increase participation in clinical trials, but also to educate both providers and the community on the importance of clinical trials and the importance of diversity in clinical trials. Okay, so we are at around 20 seconds for our session to end. Dr. Jackson, it has been a pleasure to have this conversation
Dr.
with
Dash,
you.
I gotta say, I learned a lot from your talk. I really appreciate it. And as again, it was an honor to be asked to be part of this.
I completely agree. And to everyone listening, thank you for all the work we do. Our research would not be, and things we do would not be possible without your support and your active participation. Thank you.